right. So I want to talk to you a little bit today, looking at telehealth, older adults, and how do we get people to change their behavior, especially when they want to change their behavior. So that's kind of our premise in beginning. But I'll walk you through some of what we have. I do want to acknowledge that even though I'm not on campus, I acknowledge and respect the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt, and Wasanich peoples whose historical relationships with the land continue to this day. And as I get started, I want to let you know that this project was a multi-year project funded by ARC, which is a U.S. agency for healthcare research and quality. And of course, they disavow any knowledge of my opinions as we go forward, but I'll present a little bit about our project. Just to ground us, the behavior change techniques, or what we call BCTs, are observable, replicable components designed to change behavior. So the idea is reducing the prod to the most granular level that we can. And basically it's a systematic procedure that's part of a component in an intervention designed to change behavior. So when we think about randomized controlled trials to influence diet and exercise, the idea is in creating those interventions is that there's theoretical components for why we choose the actions that we're embedding within the interventions. And so when we talk about behavior change techniques, we're talking about those little tiny granular ones. And so you can combine them with other ones to create more powerful interventions. And so we'll kind of take a look at how we use these techniques in designing e-health source of interventions. There's a taxonomy for discussing these behavior change techniques. The BCTT has 93 different techniques that they've identified, and they've categorized them in 16 different categories. And I'll show you those in just a moment. I do have the reference here for those of you who are like, I might want to get in on this. Mitchie's work has been particularly helpful, and they also offer online training. So if you want to be able to learn how to spot behavior change techniques in the wild or in the literature, there's a very nice training program that you can go through. When we look at behavior change techniques, there are the 16 categories. Some of these you'll look at and you're like, I've seen those on apps and things like that. And some of them may not seem quite as familiar. Goals and planning, feedback monitoring, social support, how we shape knowledge, natural consequences, comparisons of behavior. There's quite a number of things in here. They do contain 93 different types of techniques, some of which you will probably never see be used because most ethics boards would not let you use them, but they are actually ways to change behavior, so they do get listed. But most of those 93 are things that we potentially could use to help people change their behaviors. So I have a couple examples for you in terms of what their definitions are. So in the goals and planning category, one of the behavior change techniques is something called action planning. And it's defined as being able to prompt a detailed planning of the performance of the behavior. And that planning component needs to contain at least an element of the context, a frequency, duration, and the intensity. And by context in this situation, they're talking about environment, so a physical or social context, or it could be internal. So it could be emotional or cognitive, so state of mind, or a physical state of being. Another example in feedback and monitoring, self-monitoring of behavior. This is probably one we're all familiar with. Establishing a method for the person to monitor and record their behavior as part of a behavior change strategy. And then another one is behavior practice and or rehearsal is part of the repetition and substitution category. And this one is prompting practice or rehearsal of the performance of the behavior one or more times in a context or at a time when the performance may or may not be necessary in order to increase habit and skill. And some of these sound very basic, and they are, but they are important in how they are defined when we start talking about the design of some of these technologies and interventions. The community health kiosk, it's a multi-user kiosk. Apparently my picture will not show you what it actually looks like. So imagine a desk with a computer sitting on it. It's pretty much, that's how it looks. There is a drawer underneath, which has some supplemental measurement techniques. So there's a blood pressure cuff. There's a dynamometer for measuring hand grip strength. There's also a pulse oximeter for measuring O2 saturation. And the chair that the participant is actually sitting in is actually not just a chair, it's a seated scale. So they can sit and have their weight taken while they're interacting with the kiosk. The other piece to the kiosk that might make it slightly different from the computer you're sitting at today is that it does use a touch screen. So in addition to, they do have an option for using a keyboard to navigate, but most of our participants choose to use the touch screen and tap on it to navigate through the system. Once they entered this kiosk, there were, because it was part of a larger study that was going on, one of the things they did is they had a battery of screening instruments that they would take. And based on those particular results, they would be recommended modules that might be beneficial for them. One of the things that everybody received, no matter what their screening said, was the Managing Your Health module, where we talked about some basic concepts about goal setting and things like that. There was also a subcomponent to it, and then communicating with your providers. So there were some communication strategies aimed for participants in how to talk with their own providers about their health needs and about what they wanted to do. And there was also another module in there in case you were a family caregiver and you wanted communication tips for how do you talk to a provider about your family member. So if you're having a co-management situation working with family members. We had several different modules that people could be referred into. And then we also let people self-select as well. So just because you didn't make the score on a particular area of concern doesn't mean you couldn't get into it. It just means it wasn't in the list of the recommended. The modules we had, besides the Managing Your Health main module, we had a sleep module. We had one, we did have one on mobility, which was not activated. We had one on lifestyle, which included both nutrition and also activity recommendations. We had one for bladder control, and then we had one for emotional health, which was mostly focused on mild depressive symptoms. So there was a number of things that people could do within this. All of these particular areas or modules were actually built off of pre-existing randomized controlled trial interventions. So they had been successfully tried before. We built them into the kiosk. And as you might imagine, it was a very diverse team that built these. And so they came from a variety of theoretical backgrounds when they developed these interventions. And none of these interventions, when they were developed for being delivered in a telehealth kiosk. It was one of those quirky things. So part of our work was converting what had been the intervention in the randomized controlled trial to the kiosk environment. And that led us to some of the design decisions and matching the intentions behind the intervention and what the actual intervention looked like when being delivered by a kiosk. And I've kind of skipped ahead, but something else to know about our particular modules is that they were designed to have a time lapse in between sessions. So the number of sessions could vary for each module. Some had as few as 4. Some, like the lifestyle one, had as many as 29. But the idea was between these sessions that there was some amount of time that would elapse. Quite often the sessions had homework for people to go home and practice and to take what they had learned within the session and be able to implement it at home. And so that was also an important component in thinking about the fact that we're looking at behavior change. So we are intending for there to be a time lapse in between these sessions. The other piece to know about where these kiosks were deployed is they were intended mostly for older adults who are living independently within the community. They were open to any age person who was available within that setting, though, because we felt that that might also increase the adoption. So some of the settings that the kiosks were present in, we had them in recreation centers. We had them in independent living facilities. We had them in senior daycare facilities. And then we also had one that was in a more rural community that was co-located with social service agencies. So it was a place that folks, it was in a part of a section in a mall. So it was a place that people might visit locally. And so they were all designed to be publicly accessible for our participants. When we went through looking at what we had created in that translation of the original intervention to our kiosk, what we did is we did a review of looking specifically for the behavior change techniques. It was consensus-based. We had 3 different reviewers. All of us had completed the 25-hour training on how to recognize a behavior change technique. And then we went through every kiosk session for every module. And we did it live. We did it as if we were the participant. So we literally went through every single screen. In cases where, well, I'll show you in places where some of the data from participants would be input so that other pieces could happen within the kiosk environment. We did put in fake data so that we could see the system actually react and perform in the way that it was intended to. For the lifestyle module, when we were doing this, we did have to result to the base graphic screens for sessions 19 through 24 because those were still in development and they hadn't gone live yet. One of the lessons learned about this project, it took a lot longer, even with pre-existing interventions, to translate them to the kiosk environment than had originally been anticipated. And so for the lifestyle in particular, because there were so many sessions, as we got towards the end of this, we were about 2 sessions ahead of some of the very earliest participants. So they were always just slightly behind of what was going into production. So that was also part of the impetus as this project was rolling out, was to be able to track how are we using the behavior change techniques. And we expected to see some, because we knew of how these interventions were originally developed, we expected to see them, but we wanted to know what happened when we did this translation. And we also wanted to know what kinds of potential this type of technology offers when we start looking at behavior change techniques. So when we looked at the kiosk specifically in all of those screens, we found 15 out of 16 categories. The one that we did not find was scheduled consequences, but there were examples of behavior change techniques in all of the other categories. And I'll go through which ones were the most popular ones. I don't think they'll surprise you, but it was interesting to note the variety that were being used over all of these different modules. Overall, we had 47 unique behavior change techniques that we observed. We had 395 observations. So we counted them every single time we saw it, even if it was a repeat. And then there were 46 that we did not see. In terms of looking at the modules themselves, you can see that the number of behavior change techniques in each individual session, it did vary. It's not surprising when you look, for example, to note the total number for lifestyle module was 222. But remember that ran over 24 weeks. So not surprising that they had the highest number because they had the most number of sessions. But when you look at the averages, you can actually see that there were multiple change techniques being used in each domain area. And this was actually also important to us as we looked at this because most of the literature looking at behavior change has focused on lifestyle, so diet and exercise. And we wanted to know, so what are people doing in other domains? So what are they doing about sleep and about incontinence and looking at emotional health? So in terms of looking at these particulars, in managing your health. So that was the first one that everybody got. That module used 14 different behavior change techniques. Emotional health used 9. That was mostly focused on cognitive behavioral therapy strategies. So that wasn't surprising. Sleep had 18 different BCTs. Bladder, interestingly, used 20, and not surprisingly, lifestyle used 31. And part of that for the lifestyle component is, I think, it's also the variety, because if you're running essentially 24 weeks of an intervention, you're going to want to put some variety into how you're asking people to change behaviors. In terms of looking at the popular ones, in terms of thinking about categories, goals and planning was definitely the #1 by a long shot. Not surprisingly, feedback and monitoring was our next highest category in terms of looking at how were people trying to change behaviors. But we also had quite a bit there in repetition and substitution and doing some comparisons. And also then a little bit less when we start talking about social support, rewards, and shaping knowledge. And so when we talk about, well, where are some potentials, those are some areas that we could probably look at expanding when we start talking about building interventions for this type of technology. In terms of the actual behavior change techniques, the individual ones, the #1 was self-monitoring of behavior. And if you think about any mobile health apps that you've used, this is probably the most used technique that you encounter there as well. It was followed by action planning, feedback on behavior. Most of our modules at some point were collecting data from the participants. So it could be sleep diaries, it could be actigraphs, it could be surveys about intake for food or activity levels. There was usually some component that was coming into the system. And so that was actually giving them feedback on the results that they had collected. And then obviously there's other things in terms of demonstrating behaviors and practice and rehearsals. Some other interesting pieces in there that I thought were interesting because they were used quite often were discrepancies between current behavior and goals. So pointing out where people had said they wanted to be versus where they actually were based on their own data. And then we also saw quite a number of them were including social support. And so that was interesting to see within the context of interventions that were not built on Facebook or things like that. They were standalone interventions. And of course, now my slides aren't going to show this, but one of the things that we know in terms of looking at these kiosks is that when we look at certain examples, so we have behavioral strategies and practice. And so these where we were prompting the behavior. And so quite often there'd be a screen where we would actually show the behavior, and then we would ask the participant to give us information about when they might perform that behavior. And so that would be part of the association. So depending on which module you are, the cue might be slightly different. But sometimes, so for example, if you were in the lifestyle, you might get a cue that talked about when you first get up in the morning and what you look at and seeing. For example, if you see your shoes already set out, that could be setting up the idea of rehearsal and things like that. So there were quite a number of different types of behaviors and that were embedded within the system. And I'm just going to scroll down a little bit more. And I think I gave a number of pictures, which of course don't show up here. But one of the interesting things that we did find about looking at these screens and going through them was that the technology in some respects did limit us in terms of what we were able to translate. So there were some things that just like when we talked about the lifestyle module, the original intervention had a lifestyle coach. And we still did have a live coach, which came in at certain points. And that was using a video-based interaction. But one of the disadvantages is that that wasn't something that was easily replaced within the system. But there were other advantages to this technology in terms of returning data and giving folks a way of looking and visualizing their own information that had not been originally envisioned within the original interventions, because the technologies that they had done when they were doing the randomized controlled trials didn't offer that level of feedback. So things like trend lines rather than just the immediate data. Those kinds of things were opportunities that, in building forward and thinking about the interventions you can do, those are definitely ones that, looking at behavior change techniques, you can actually embed that within the design itself. Okay, and I think I'm right about my time limit, so I'm going to go ahead and stop sharing, and I'm happy to answer questions.